My name is Sandro, Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school and of our medical campus, welcome to this public health conversation. These events are meant as spaces where we welcome public health leaders to our community to talk about issues of consequence for health. Thank you for joining us for today's event, in person or online. In particular, thank you to the Office of the Dean, whose efforts make these conversations possible. Now, before introducing today's program, a couple of logistics. First, today also happens to be, in exactly 1 hour, the Red Sox opening day. Now, I mentioned this, there's actually a reason why I'm mentioning this, because there is going to be a jet fly at some point in the next hour, which apparently can be quite loud. So if that happens, that's what's happening. That's number one. Second, the format of today's event is a Q&A. I will be asking Dr. Walensky questions for about 30 minutes, and then we're going to open it up for questions from the audience. In order to make sure that everyone on Zoom can also hear the questions, we are not going to do raised hands in the room. Everybody should have received QR codes. There's little QR codes floating around the room. So all you need to do is just scan the QR code, type in a question, and I'll have it on my iPad, and I will do my best to get to as many questions as possible. And now to the event. We have the privilege of welcoming a very special guest. Dr. Rochelle Walensky is the Director of the Centers for Disease Control and Prevention and Administrator of the Agency for Toxic Substances and Disease Registry. Before going to CDC, Dr. Walensky served as Chief of the Division of Infectious Diseases at Massachusetts General Hospital from 2017 to 2020 and a Professor of Medicine at Harvard Medical School from 2012 to 2020. Originally from Maryland, Dr. Walensky received her Bachelor of Arts from Washington University in St. Louis, her Doctor of Medicine from the Johns Hopkins School of Medicine, and her Master of Public Health from the Harvard School of Public Health. On a personal note, I've had the privilege of intersecting with Dr. Walensky in various venues, and I've always learned from her and enjoyed our interactions. So I'm really delighted that she's with us today. On behalf of our community, Dr. Walensky, welcome. Welcome.
Thank you. I'm so delighted to be here.
All right, so we're going to start with an easy question. Let's start a bit with your background, how you came to work in public health, your journey.
Well, maybe first, as I just even first scan the audience, I just want to say I'm among mentors and friends. So it's a delight for me to be here. I'm delighted to have this conversation. So thank you to all of you who are here and supportive and who have supported and shaped me in my journey. So I came into public health because in 1995 I was an intern. And as an intern in 1995, you admitted mostly patients who were dying of AIDS. And later that year was when the cocktail was FDA approved. And all of a sudden, during that year, people went from a definitive death to you may not die of this disease. And there was so much work and public health work that was happening during that period of time, and so many unanswered questions about how that path would go for those patients that I really wanted to be a part of it. And so a lot of what I wanted to do was take what I was doing at a patient level and sort of bring it to epidemiologic analyses, ultimately cost effectiveness analysis. And so that was really how I started a journey in public health and learning the methods, quantitative methods, during my master's. Maybe one other anecdote, and that is people have asked me, how did I apply for this job? And the answer is, I didn't apply for this job. I got a phone call one day asking if I would be interested in this job or would consider this job. And sort of that's how it happened. That's how it happened.
And here you are.
And here I am. I will say I never in my career aspired to this. It's an amazing honor and an amazing privilege to have this job, but never in my career did I sort of say, what I really want to do is be the director of CDC.
So, now let's move to content. So I'm going to divide my questions into COVID and then non-COVID.
All else.
Let's start with COVID. Let's start with what you think were the main mistakes that we made during COVID. And insofar as you're comfortable talking about it, what mistakes you think the CDC made? And then to leaven that, also what you think we did right.
Wow, we're going to start easy, huh?
Well, the first question was easy.
So, I think first, I think it's probably worth rewinding and saying I inherited the CDC as a pretty frail organization in January of 2021. The CDC director position is not a Senate-confirmed position, so I was sworn in about a half an hour after the president, knowing that we needed a lot of work in public health immediately. So there were mistakes that predated me, also mistakes that were made under my watch. I'm going to acknowledge those too. I think first thing we need to acknowledge is CDC is an agency that's 76 years old. The last pandemic was 105 years ago. And so CDC has never in its history had to address a public health outbreak the size, scale, and scope of what we had to do in this moment. And so while we have been positioned to do lots of things in public health, that the vastness of that responsibility had never been one that CDC had been sort of primed for. Certainly there have been mistakes or challenges that have been talked about in terms of lab and in terms of other things. Among the things that I will sort of say I look back on are things I think that one of the things that I would have wished for initially is I said in my nomination speech, we're going to lead with science. And I stand by that. I assumed, which was not appropriate, that the people who were listening understood that science would change. And scientists, academics understand that, but not everybody understands that. And so we should have said science and it will change, or science and for now, and this we will update and give you more information as we have it. I think one of the challenges that has happened in all of science is that conversations that we are used to having in academic audiences, in scientific meetings about, should we do this or should we do that? There's a gap in knowledge, that is gray, we need more information on this thing, was now a 2-minute news bite on NBC Nightly News and was being digested for all of America. And that was hard because not all of America can interpret the science the way trained academicians interpret science. So that has been difficult. And so implementing that sort of science is going to pivot, science is going to change as we have more information, not only as our science gets updated, but, oh, by the way, in this situation, as the virus changes too. So that has been really hard. The other thing that I think CDC had been unaccustomed to is people who knowing who we were. Not your average American does not come to the CDC, or did not in 2018 come to the CDC website to figure out how they should clean their apples, and now they were. They knew who we were and what we did, and now the average American was reading our guidance. And then finally, I will say our guidance, and we've moved a lot and changed a lot in how we put these recommendations out, had been do this but not that. And it hadn't been sort of a harm reduction kind of approach to guidance. And so that's hard because, and as I've had this great privilege of traveling all of America and our territories and tribes, our guidance has to apply to Manhattan and tribal country and Guam and rural Idaho. And so one set of guidance is to say that it's going to apply similarly across all of those different kinds of places. We need to provide options for what you can do in your place when you have these resources and this capacity and this sort of political will.
The point that CDC had never actually been through a pandemic is a really interesting point. I never thought of that before, 76 years and 100 years. I'm going to go off script for a second. Let me pick up on the science. And you said, I want to lead with science, and I assume that people would know science changes, and of course, scientists know that. What role do you think the fact that we lived through this pandemic in a time of social media, which really science has never really lived through an emergency in social media, where anybody says something and it, by definition, because of the medium, it seems dispositive. What role do you think that played?
Huge, because I think a lot of the mis and disinformation has been propagated by that. So on the one hand, and the other thing is that is where in social media and on Twitter is where scientific dialogue could potentially disagree. And that's a really fruitful, we like that kind of active discussion and disagreement, so we can't tamper it. But at the same time, it's not always used for productive purposes. Mm-hmm. So I think that's actually it's been a really interesting, really difficult space right now for social media. and how I navigate social media and how I use social media has even evolved in my tenure there.
Yeah, absolutely. Where do you think we stand on credibility for public health broadly, CDC specifically? There was a paper, which I'm sure you saw the other day, came out in Health Affairs about trust CDC. It was interesting. How do you feel about it? Where do you think we are?
Well, let me just say in that Health Affairs article, I was pleased to see that CDC was on top of the other federal agencies. So I do want to say, I think that trust, we have work to do. And I don't think it's CDC alone. I think all of us have work to do. Science and academia has work to do in how we demonstrate and regain that trust because it has been so politicized. One of the things that was the case when I came to CDC is our science was moving slowly. Has anybody ever tried to put a paper out with CDC co-authors? I hear people laughing. I was a co-author at the time I started at CDC, and so I knew that. And I said to the agency kind of the day I walked in the door, science gets out too slowly here. We have decreased our clearance time by 50% since the day I walked in the door. That's still too slow, as far as I'm concerned. And in fact, some of the things in terms of credibility is to be accountable and to say, if you think your science gets out too fast or too slowly, prove to me it's going to get out faster. So one of the things I think I'm really proud of is Mpox vaccine performance. We were the first in the world to put it out. And we put it out via a technical brief on our website when we were pretty sure as to what the data were showing, and when it was going through peer review, so we had every intent of putting it through peer review, but people needed to know how that vaccine was working. We just, last week, 2 weeks ago, put out a technical report on where we are with avian influenza. So these technical reports, getting our science out faster, I fully believe in the peer review process, and we still need to continue that peer review process because it makes it better, but oftentimes to be action-oriented in public health, we actually need to give information in real time before the ink is dry on the publication.
Interesting. Let me talk about the politicization of science, which you just mentioned. So there's no question that we have, in the spirit, certainly in our professional lives, it's never been this bad, where science is so politicized. So this is where we are. How do we get out of this? I think it's easy to agree that we shouldn't be here. How do we move to a place where actually public health can occupy a unifying ground rather than being split as it is right now?
So I would welcome academic voices on this too, because I do think all of science has been diminished by politics. And I do think sort of being credible, being accountable, demonstrating, coming back, when I meet with members of Congress, when they say X, I'm like, let's unpack the data there. What do the data actually say? So, one person at a time is one way to do it. I do think, though, that especially in sort of the space that I'm living these days, health and policy, they are interrelated with politics. By virtue of the fact that health and economy and school and name your other travel, name your other many of your other spaces are values judgments. Do you place value on your economy being open over your risk of health? Those are values judgments, and we don't get to decide how everybody else places those values. And at that intersection is politics.
Do we have a role to play in shaping values?
I think we have a role to play in helping to understand risk. And I think we have a role to play in providing accurate science to help shape those values. But I don't think we get to say it's more important to have this amount of risk than it is to say that economy, that your value on economy. And I think we all should acknowledge, as we think about some groups that have zero risk tolerance, to say, well, if an economy is closed, that has really important downstream health implications, and we can't forget about those as well.
Let's move to a case of what I find both troubling and interesting about balancing risks, which is China's zero COVID policy, where we saw, and I realize there's some things you may be able to say, some things you may not, so obviously you'll say whatever you're able to say. But certainly the read from the outside was that there was a draconian effort made to say we're going to eliminate risk when there was no real biological reason to believe that was possible. Then, of course, it was reverted and resulted in all sorts of risk. But at the same time, these trade-offs were made where people's fundamental human rights were being sacrificed for this notion of zero risk. And I think what troubled me most about the moment is I did not see public health voices pushing back against that. And from inside China, there are constraints, or from outside China. So I'm just wondering what our role is. What is our role at helping guide reasonable trade-offs, helping guide balancing risks and other values that we should be holding central to our societies?
I think we have a really important role there, and I think, but it's also, I shouldn't say but, I should say and, everybody is going to have a different measurement of either understanding those risks. I did a lot of work in risks and probabilities and decision science taught by some of you all in this room. And even good, smart people who understand these trade-offs still have a hard time processing. And so I think that is our responsibility. I do think there was probably more work that was done than may be apparent to the public eye in trying to understand this. And I do think when you think about what happened in the purposes of zero tolerance, zero COVID risk in China, ultimately what happened was there was no innate immunity or no infection-induced immunity, and that didn't necessarily serve them particularly well with regard to
when they changed their mind.
Well, yeah.
Can you draw a through line from what you learned dealing with the HIV epidemic all the way through COVID, Mpox? Like what brings those together for you?
First of all, community. It was so helpful for me during Mpox to know that community, to know the advocates, to be able to pick up the phone, which I did almost on a weekly basis, and say, I don't even know if this is in CDC's lane, but what's the community feeling? Who's hurting out there? What can't you access? What are the challenges that you're having on the ground? We can have a whole nother conversation about Mpox, but one of the real challenges was, in my mind, we in this country do not have what I call the Amber Alert for clinicians. How do you all of a sudden, in a heartbeat, say, there's a new disease out there that you need to know about when somebody walks in the door, and you need to know how to test for it, you need to know the questions to ask. We don't have that kind of capacity in this country at that level. And so much of what we heard early on was, I went to 5 clinicians and nobody knew what it was, or nobody knew what to do for me. And that was some of the delay. I will say the other thing, I vividly remember where I was in Mass General as we were having the conversations and we were talking about isolation and quarantine very early on in the pandemic, and people would say, well, all you need to do is quarantine for 14 days or whatever it was at the time. And nobody was asking, can you do that? Like these households that had, 8 members in 2 rooms and 1 bathroom. It's like, and so much of that I learned and was bred in taking care of patients with HIV, that we just really, and this again goes back to our CDC guidance that says, these are all the things that you say we should be doing, but what's really possible?
All right, I'm now going to shift out of COVID. I'm sure it's a relief. Let me just talk about other things.
I've talked a little bit about COVID over the last few years.
I'm sure you have. I'm going to ask 15 more minutes of my questions, then I'll turn to audience questions. Let me start with again, an easy question. What are you most proud of in terms of your work at CDC so far?
The people at CDC are just incredible. It's just, every day is a humbling day. So maybe I will just sort of give some examples. So for those of you working in public health, and I know like that's everybody in the room or at least thinking about it, our job is successful when nobody hears about public health, right? And that is really hard to sell. It is. So things like there were about 80,000 people who came into this country in August, a year and a half ago August, in Operations Allies Welcome from Afghanistan, quickly brought into this country. We had an MMWR on this issue. There were 44 active measles cases. And none of them went to the community. That's kind of astounding from an infectious disease standpoint. It was in an MMWR, but very few people, deans might not have even known about it.
This dean was not aware of that.
Right, and 14 active mumps cases. And a lot, so there was that's a massive public health success.
That's amazing.
And so when you think about those kinds of things, we had an EIS officer, this is a good sell for EIS, who rappelled out of a helicopter to drop test kits to the Diamond Princess. Those are the kinds of things that people, or in Mubende, Uganda, doing infection control in the middle of the Ebola Sudan outbreak. So like those are the kinds of people. Now, their names may not be on publications, and you didn't know about their work until I just said it. But that's the kind of people that I get to represent. So it's pretty extraordinary, the kind of work that is happening. I could talk certainly about 673 million vaccines that have been administered in the last 2.5 years. Unbelievable, biggest vaccine. I could talk about the fact that after about 1.5 years, we had complete vaccine equity in this country. In fact, the biggest challenge in vaccine equity was on the urban-rural divide. Not on race and ethnicity. I am really proud of the fact that within 10 weeks of my showing up, we declared racism a serious public health threat. And within, 1 year, there were 200 public health departments that had done the same. So there have been some real we established the Center for Forecasting and Outbreak Analytics, which I think is going to be a really incredible add. So there's a lot that I think we and the CDC have to be proud of. We still have a lot of work that we are doing, and a lot of lessons learned. Through COVID again, public health again, through COVID 2021, there were 63 foodborne outbreaks that year. Not many made the news, but they were all sort of addressed. So there's just a lot of work in public health. So every week I make unsung hero calls of people within the agency who may or may not have had their name in the news or recognized for their work, but who are doing incredible work every day.
Well, rappelling into the Diamond Princess with test kits is also pretty cool. I did not know that story. That's a great story. Let me ask you a big picture question. In public health, we often talk about our role is to create a healthier world, to build a world that supports health. What would be your vision for that, and how do we get there?
So there are lots of different ways I could go with that. So first of all, COVID happened on the top of an incredibly frail public health infrastructure. There have been some that have said that we were 60,000 public health jobs in deficit at the beginning of COVID. So a huge amount of work that we have to do in workforce, in data modernization, fax machines. We're receiving data by fax machine, and 1 million COVID tests a day by fax machine, and laboratory infrastructure. Do we have a lab? Every jurisdiction wants us to be monitoring their wastewater and doing genomic surveillance, but does that county? Does Maricopa County, Arizona, have wastewater surveillance and a genomic epidemiologist at the ready to do the analysis? So a huge amount of work that we have to do in public health infrastructure. My vision, and it will postdate my tenure, I suspect, is that public health infrastructure has to connect with healthcare, because we are the only probably the only country in the world where those two are siloed. And if there were an EVALI outbreak, it's one thing to have a measles outbreak where it's a reportable condition, but for those things that are not reportable, an EVALI outbreak, the e-cigarette associated lung injury outbreak, something like that, and it was sparse around a whole bunch of different hospitals, it takes forever for somebody to realize there's a problem because public health and health are not integrated. So I would really love to see those two data systems plugged together. That is sort of the infrastructure piece is a really important one, and the equity piece is a really important one. There are so many people. There's some scientific literature that suggests from the time of a new a new therapeutic, to the time it gets to community, and I just did an event yesterday for community-based organizations, is 17 years. by the time it gets published, and then it gets into the guidelines, and then academics start using it, then community members start using it, then it goes generic, like it's 17 years. We can't have that delay if we're going to have equity and health around the country.
Let me build on the equity point. Can we talk a little bit about health gaps, about some of the sort of intractable health disparities, health inequities in this country along multiple lines: education, income, race, ethnicity? Where do you see the CDC playing its most important role in narrowing those health gaps?
So we think we have to actually see them. So as you're talking about social determinants of health, I'm talking about health data and public health data, but there's like a whole nother level. Like, can we link our housing data? Can we link our environmental justice data? Can we link our climate data? Because, and in fact, can we think about the fact that highway was built through an African-American neighborhood to connect a suburban neighborhood with the city, and therefore there's no green trees, and therefore there's no safe space. So I think that there's so much work that has to be done in that space.
Let me shift topic. I want to ask about sort of a larger topic about commercial determinants of health, and I want to use the East Palestine train derailment, which I'm sure you've, in both your CDC hat and your ATSDR hat, you've been dealing with. I think there's much to be said about East Palestine, but clearly, right, it's a confluence of forces largely arising from practice of the corporate sector. And there's more and more academic work about working with private sector to align what the private sector does in a pro-health way. Can you just talk a little bit about how you see the CDC intersecting with the private sector in a way that generates health, in a way that encourages, incentivizes the private sector to generate health?
Yeah, I mean, there are so many complexities about East Palestine, and I actually just got back from Hawaii and spent some time talking about the Red Hill oil spill. So there's like a lot of.
That was my next question.
Great. So first, I think there's this regulatory piece that is really an EPA's space. So we offer sort of the assessment of chemical exposure, but the regulatory piece is EPA's space. Interestingly, in East Palestine, there's HHS, there's EPA and CDC, there's HHS, and it bridged two regions. Because Pennsylvania, so there are a lot of players there in terms of both regulatory and health outcomes. So CDC's role for the most part is to assess the chemical exposure and to sort of do long-term follow-up. I think many people don't recognize that oftentimes in many of these we have to be invited in order to be able to do that assessment. So we have been on the ground in Ohio, and what we really like to do is especially provide community information that they need to do the assessment of chemical exposure, to understand what those long-term impacts are, and then also to understand and do the sort of science behind what is the potential impact of those exposures before and after they happen.
And how can or does CDC work with private sector, with corporate entities to encourage them to do things that improve health? That is one of the partnership areas where we have more work to do. From a sort of environmental standpoint, much of that happens with the EPA. Right. Different topic, technology. So, I'm often frustrated by how we discuss technology in health and public health, because it's often discussed as like the panacea, the solution. At the beginning of COVID, we saw this, right? Apps are going to save us. Of course, they were utterly useless. But obviously, technology plays a role. So I'm just actually curious about your thoughts on that, about how we can actually use technological advances to advance the health of the public in a meaningful way.
I can give you, so you've named a bunch of examples of where it's been challenging. I just got back from Vietnam, and on a Saturday in Vietnam, in a middle school or in a grade school, they were doing TB screening of elderly people. They had radiographs, chest x-rays that were about 6 pounds that they were doing in this site, and they were being read by AI in real time. And they were screening somewhere between 300 and 400 a day, a positive chest x-ray, you marched down the hall and got your sputum. We can do AI looking for cooling towers to detect Legionnaires outbreaks. So there is a lot of work that is happening in technology where I think it could be really helpful. I could talk for hours about data challenges, but one of the ways that could be really useful is how can we use technology to protect identifiers so that we can actually have more data on more people without the threat of identifiers, personal PII getting out.
That's interesting. Those are good examples. All right, we're going to switch to some questions from the audience now. I'll start with one from Zoom. That's a good one. Looking ahead, the greatest public health challenges, let's say, of the next decade.
Well, I was just saying ahead of this, it's been raining infectious diseases since I got to CDC. I don't think that's going to change. Everybody thought that the next pandemic would be an influenza pandemic, and it wasn't. And just because we had a COVID pandemic does not mean we are protected against an influenza pandemic. Our Emergency Operations Center has been continually activated since I've started, and had already been. And so I think that we will continue to see infectious disease threats. And we need to be ready for the next pandemic because, I think we had a frail public health infrastructure coming in, and we're doing a lot of work to bolster it, but it's not where it needs to be. All of that having been said, the people who are most impacted by infectious disease threats are those with chronic conditions. And it is the intersection of those chronic conditions. And until we bridge that equity gap between the people who are dying of chronic conditions and most threatened by infectious disease threats because of those chronic conditions, we will not be ready.
Separate question, I quite like this one. How does the CDC and you handle competing priorities? And the example that's given is the opioid epidemic, which preceded COVID and has no end in sight. And how does the agency balance these sort of multiple deadly diseases and the pros and cons of doing one thing which may actually well harm another?
That's a great question. So I am fortunate to have an agency that is 12,000 strong, if not more. We have different centers that are responsible for different areas, and I would say critically important so that, and this I think is a perfect example, it doesn't speak specifically to opioids, but when we had the Zika outbreak, we were swiftly able to bridge our birth defect center with our infectious disease and zoonotic disease. So it was those expertise that were able to come together that allowed that response to be so effective. And so it is our ability to bridge. So when we have a challenge in, be it HIV and opioids or something like that, we can actually bridge those gaps pretty quickly. The next layer of that question is, in an agency that has 12,000 people, what happens when you have a pandemic and 2,500 of them need to be deployed to that response? That's how many people we had actively working in a response at a given time. And so much of what I have said to the agency is we need to have a responder program. Everybody at this agency needs to be part of this response, whether you book flights for deployers or you're a subject matter expert on A, B, or C. And at the time when you have to really deeply engage in a response, how do we know what to let go of? Right? How do we know the things that are not acutely important today because I really do need to tackle what's happening in that seafood plant or an outbreak that is happening somewhere else?
Let's talk about climate change. This is a question from Paige. How is the CDC preparing for the diseases that will emerge or worsen due to climate change?
Well, CDC is the only part of U.S. government that works at the intersection of climate and health. There is an office that's being established in the Office of the Assistant Secretary. I think one of the major issues that we need to talk about is where those intersections occur, because I think most people don't recognize where those intersections occur. So if you go to Alaska, you do not recognize that the climate change is affecting their food security and salmon and tribes. You don't recognize in Minnesota that they've had some of their wells that have been overrun with water, and therefore their water security is a problem. They don't recognize the expansion of vector-borne diseases, where we're seeing Babesia now, where we're seeing Lyme now, and the environmental heat index. So I think people sort of say climate doesn't affect me. Climate affects all of us, and I think people need to start to recognize. It may very well be that we need to talk about it in a language that is acceptable to whoever may be talking. You know, what does it mean for the cruise industry? What does it mean in language that doesn't necessarily use the word climate for everyone? Because not everybody is ready to acknowledge those intersections. Well,
let's go from an easy topic like climate to an easier topic like firearm violence. So what do you see is the CDC's role in, it's a question from Mohammed in the room, in contributing to evidence-based strategies and policies to reduce firearm violence? And how do you see the CDC intersecting with the public health community at large on this issue?
So we did declare firearm violence a public health threat 2 years ago, soon after I started as well. You can't address this question without sort of addressing the tragedy of like even just this past week. So let me just say that as a parent, how terrible and tragic and unfortunately common this is becoming. We have had numerous reports on firearm violence. I think one of the big tragedies in the big picture is that these happen when they happen in mass, and six shootings in a school. But over 70% of homicides and over 50% of suicides are related to firearms. And so the one-offs we're not getting as we don't get the news on, and yet they are so very common. We do have resources now. They had been expanded under this administration to do some research now on firearm prevention. One of the firearm violence prevention on how do we even have a database or a surveillance on those who have had firearm-based injuries, but not only deaths. We don't even have the surveillance on that. The other thing I will say, and this was something that I think is really important, we do have to come to terms on what we agree on across the aisle, because we have to get to yes. Can we agree for firearm owners and not that we do not want to have loved ones die unnecessarily of a firearm death? Let's just agree on that. If we can agree on that, is there a place, I've been to a firearm training facility where they were teaching 8-year-olds to shoot. What is it that you should also be teaching your 8-year-olds about safe storage, about how we engage in prevention of community-based violence? What are the things that we can agree on to say, let's get everybody to the table so that we can agree?
Thank you. That's actually an excellent answer. Let me ask a question from Andrew in the room about COVID undercounts. There have been some papers looking at undercounts of COVID deaths, and that they're particularly pronounced in low-income communities and communities of color. Can you just talk a little bit about the CDC, what the CDC is doing to address that? And I think this ties in some of your data systems comments you made earlier.
Yeah, so there was a Washington Post piece a couple weeks ago about whether we were undercounting COVID deaths. And for those who haven't seen it, in November 2021, or 2022, we actually had a scientific brief on how those COVID deaths get counted. And I would invite people to look at that, because it really, Deb Powery actually just had a reply to that Washington Post editorial. We have to rely on, and this will change at the end of the public health emergency, lots of different ways in which we get data. We can get data from the states in line item way, and then we get data from our national health statistics in a delayed. So everybody wants data fast, but they want it right, and sometimes those are mutually exclusive. So we actually report both, and then we report the comparison. And in the comparison, they're actually not too far off. But our data do report that. One of the challenges that came up in this op-ed was, are we reporting with COVID or for COVID? And it is very clear that COVID has to be, for it to count in health statistics, it has to be on the pathway, the causal pathway of death. So it's either, and more than 70 to 80% are the cause of death, or they're a high-level contributing cause of death. That's the other 20%. So when COVID is reported, it is reported as either is on the causal pathway, and we're very clear about that. It does. Maybe I'll just speak quickly to an issue related to data authorities, because this is just so near and dear to my heart. We're doing so much work on data modernization, but I think many people don't recognize, and so I really would invite you to be part of the ongoing beat, that we receive data at CDC voluntarily in the absence of a public health emergency. We receive data voluntarily, unstandardized from, wait for it, 64 state and 64 state and territorial jurisdictions, 3,000 counties, and 574 tribes. If it's not standardized and it's voluntary, you can imagine the kind of patchwork of data that we are receiving. And so one of the things that I would really like to do is have some standardization and some authorities for the data that we receive.
Last week, the CDC report on maternal mortality made quite a splash, appropriately. And for those who didn't see it, it showed maternal mortality is at its highest that it's been for about 30 years. What do you think are the most urgent action priorities on that?
Well, I think that there's some of those were related to COVID and some of them were not. We specifically dug in to see, were these increases, was there sort of a hockey stick change in shape that was related to COVID? And it doesn't, they were increasing before. There are certainly these are certainly under racial and ethnic divides. And part of this is getting into the community and understanding the root causes of these. Some of this is access to care. Some of this is education and making sure that there are community-based organizations to support the social determinants of health that lead to some of these challenges. We have an active engagement in this, but I will also say that this is also it's going to be a moving target because many things will change after the Supreme Court ruling, and we have to look at that piece as well.
Totally changing tack. You mentioned that you took over CDC at a point where it was a fragile CDC. What's the biggest lesson you've learned since you've been there?
In April of 2022, we took on a review. It was to say, like, what have we learned in this pandemic? What were we not ready for? We talked to over 100 people, and we saturated in sort of what we learned. So I will tell you the 5 sort of lessons that kept coming up. One is you have to move your science faster. You need to have science out in real time. 2 is you have to have guidances that are implementable at all different kinds of areas. We talked about sort of the harm reduction of that. 3 is that we needed to communicate it better, and there's a lot of work. Just to give you a sense and the fragility of things, I inherited an agency that has 200,000 web pages. So we are working on an Operation Clean Slate to sort of, yeah, I see all the jaws dropping. Yeah, I know. So, you know, are they all accessible? How do we archive them? What do we do with all the data that people may want to see the archives? Some people, you know, they have to talk to healthcare providers. Some have to be able to talk to public health providers. And some need to be able to talk to the whole American public. So we are working on that. So communication is a big one. Second is we need a workforce that's ready to respond. And that means, you know, at CDC, that means at public health across the country and it means public health around the world. And I'm really happy to see our field epidemiology training programs. We operate globally in 60 countries. And I've been to several, not all, but talked to country directors around the world as how we're training the next generation of public health. And in fact, we do that by creating leaders. And then finally, being a better partner. The dialogue with CDC has not always historically been one of listening. It has been one of telling. And when I have said, we need to understand what are your challenges and pressure points on the ground, and how can our work together help. That's true of public health. We haven't been a particularly always good partner of academia. We haven't been always a particularly good partner of industry. So those are some of the things that we're working on.
There's a lot of questions about leadership which I want to get to, but I can't resist tying to what last thing you said. So what have you learned about yourself and about your leadership in the time at heading CDC? It's not from me, it's coming from the iPad.
Well, there has not been a lot of time for self-reflection, I will tell. It's been hard. There's no question that it's been hard. My job is, I think, to understand the challenges within the agency and to reflect the agency in the best possible light. Certain lessons, I don't read Twitter before bedtime. I certainly don't read the comments on my post before bedtime. I have to listen and read the media and then sometimes ignore it. I need to know what is being said because it's really critically important for me to understand what the public is reading. And then I need to be able to tune it out because I can't always do my job if that is what drives me.
Let's talk about communication. There's a question here about from Jen on Zoom. Obviously, a lot of what has happened in the past few years has been challenges in communication and communicating technical information, difficult technical information. What do you see ways in which we actually can get better, accepting the fact that the technology we're using is imperfect, that we have this fragmented media landscape, social media and all that, so that we can get better at communicating technical information in a way that the public understands it?
I would invite your participation, your help, because I don't think we have schools of public health that are trained in risk communications. And I do think we need more training on that. I spent some time thinking about, like, what do we do about social media in this? How do we communicate on social media? But I also think that one of the challenges in health and public health is, and certainly through this pandemic, is everybody wants, when I put my stethoscope on, it was, I look at the guidance and I say, why or why not does that guidance apply to you and your situation? That's what healthcare providers do at this intersection between population health and people wanted to know, what should I do, as well as what is happening in the public, at the population level, and that is really challenging. And so if I've learned one thing, it is we really, when we talk at a communications level, we really need to sort of not get drilled down to but if you have A, B, and C, do this, and if you have X, Y, and Z, do that. It is, in general, we believe this is true, and you should talk to your provider about your specific situation.
We're entering the last 10 minutes, so now we enter the advice-giving part of our conversation. There are a lot of questions about advice. People want to pick your brain about that, which is wonderful. Let's start with universities, broadly speaking. So what do you think universities need to do, and universities broadly, schools of public health perhaps specifically, to better prepare the next generation of leaders in public health and in health?
First of all, I would say, and applications, you would know better than I, but I had followed some trends over the last couple of years. My understanding is applications are up. At least in general, I know public health nursing, the applications are up. That's really promising. It's going to take a while to foster this next generation. What I would say is, given the beating that has happened out there, there was just this reverence that happened in the first year, and then this beating that happened the next two. It's such an incredible field, and we just need to make sure people realize what an incredible field we are all have this great privilege of being a part of. And I do think that that will happen, because this last 2 years, I think that will be part of history, and people will continue to understand what an incredible place and field this is. I think there are areas that we need to bolster. I do think we talked about risk communications. That is going to be one intersection of what happens in social media, as we talked about, I do think data is going to be a really important one. I don't necessarily think we're training our public health youth in informatics. In fact, when I go to public health, departments of public health around the country, they say, my workforce doesn't know how to use your North Star architecture in data. And so how is it that whether it's data analytics, data entry, informatics, all of those big data things that are really, we need to cross sectors in order to do that. So I think that we need some training there. I think that we could benefit more from externships or internships, if you will, with departments of public health. We're trying to do some of that at CDC. What does it mean to be on the ground in the middle of a Department of Public Health and the politics associated with that? What are the things that you have to navigate when you're in those spaces? What does that look like? We're trying to do a lot of that at CDC so people sort of understand this is what the guidance or the work that you're doing at the federal level. This is how challenging it is to implement that on the ground in LA County or in a different place. So those, I think, and then the final one is partnership with community. I do think we had this great gift during COVID, if you will, and that is not acknowledging the incredible tragedies that COVID delivered to us. But one of the gifts is that we raised up community-based organizations and we got to community. And we are at deep risk of losing those connections because we don't have resources necessarily for them. And so I think it's going to be critically important to foster those connections, and I think academia can play a really important role in the implementation with community. I hear over and over again from community-based organizations that they want to apply for a grant, but they don't know how, or they don't have the resources to, or they need help. And so that is really, I think, an important place that academia could contribute.
Can you name 2 or 3 skills that every public health graduate needs? It cannot be more than 3.
Stamina.
That's a good one. We don't have a class of stamina right now, but we are working on it as we speak.
Wow. With stamina, stick-to-itiveness, whatever it is, because you really do need to pursue hard stuff. And so that I think is really humility, I think is another one. There's so many different flavors of what you can do in public health. Not everybody needs to be a good communicator. Not everybody needs to be a good informatician. But some sort of sweet spot skill set, I think, subject matter expertise, du jour is sort of the third, I think.
Like stamina, stick-to-itiveness, humility, and knowing your stuff.
Yeah, pretty much.
Those are 2. Okay, got it. From Nicole in the audience, as a successful woman in the public health field, what advice do you have for young women specifically entering the field? Young women.
So I would say embrace it. Every once in a while, and I will tell an anecdote. As a junior faculty member, I was invited, maybe not so junior, I was invited to give a talk. And if it's like Nicole, I think it might be, then she might even know this story. And that is, and I was told we need a woman on the podium. So one might have said, well, I'm not giving that talk. But instead I said, I'm going to give that talk, and it's going to be the best talk I ever give. And because of that talk, I'm going to be invited to give more. So sometimes you just need to embrace it.
That's good. Last 2 questions. Number 1, mistakes. What mistakes do you want to ward the future leaders in public health away from?
I think the biggest one is backing down after you've made them. Because yes, we're going to make mistakes. That's what makes us human. And so, where are there moments that I wish I hadn't said A, B, or C, or hadn't done X, Y, or Z, or wish I could have taken that moment back? wish that that headline and that photo wasn't like that, you know. But you just gotta pick yourself up and keep going. So I think the biggest mistake would be to cower under any of them.
That's excellent. Well, you get the last word. What do you want our academic community, public health, medicine in the room, and particularly the future leaders in these fields over the next 20, 30, 40 years to know? What do you want them to take away from this conversation?
Maybe just a couple of things. First is I never thought I was going to be an AIDS doctor. I thought I was going to be a dermatologist, frankly. And I took this like acute turn when HIV was happening in front of me. And so I didn't expect it. It was not necessarily something I was embracing. And in fact, I almost resisted it. So like when those atypical, not even atypical, but when those turns come your way, don't be afraid to pursue them. Because it really could be, you know, the things that, like, when you're in your pajamas and you'd rather read that paper than go to bed, that's what you should do, right? Because that's what's gonna really, like, motivate you. I would say ask big questions. I have a dear friend and mentor who says if it was easy to answer, somebody else would have done it. The hard ones are really hard, and so don't be afraid of the pursuit. I generally say surround yourself by people who are smarter than you, and don't be afraid to do so. And don't be afraid to surround yourself by people who will, you know, tell you you're wrong, or give you a different point of view, because that's actually what makes us all richer. And then I will generally say, step into things that feel bigger than you can handle. I say that with the utmost humility, because you know, that is what keeps you engaged. If you're not like a little bit nervous for your next step, then it's not big enough.
Dr. Walensky, thank you. Thank you for everything you're doing.
Thank you.
And to everybody in the audience, thank you for joining us. Thank you for joining this conversation. And thank you for everything you are doing for health. Everybody have a good afternoon.